Hello, Jeff Flack here, and it's Black Friday, and I know people are out shopping, getting their great deals, and I'm home doing a vlog, a video log on Medicare. Isn't that exciting? I know I have people that watch internationally. If you're excited about the USA and how our Medicare program's working, feel free to stay tuned. If not, click away. Today we're going to talk about the new PDPM model and how it's affecting reimbursement in the first month of operation. If you're thinking that the sky is falling, I'm wearing this retro Livestrong. I want to say after Thanksgiving, I'm thankful that it still fits. Some of you might say it doesn't fit so well, but I think black is slimming, so I'm wearing it. I got the data from Skilled Nursing News. It's an e-newsletter that I receive on a weekly basis. It has lots of good information in it. Yeah, it's up to date and it's free. So feel free to sign into it. Now, we've been through many cycles, many iterations with the RUG system. And the RUG system is the Resource Utilization Group. And what that does is that if an individual in the Medicare eligible range is admitted to a hospital and they are there for 3 consecutive days for 24 hours, they are eligible for Med-A in a skilled nursing facility, which allows them 20 days, the first days at 100%, and the rest they pay a copay. And under the RUG system, the skilled nursing facilities got reimbursed depending on how many minutes per week of skilled services were delivered to those individuals. And astonishing enough, 70% across the board were in the ultra or 720 minute range, and they got the highest reimbursement. What Medicare did is audit those cases and found a new way to reimburse nursing facilities, and I know a lot of us were concerned, are we going to make money? And I've been in healthcare for so long, yeah, we can still make money. What the PDPM rate does is the patient-driven payment model, and it's based on 4 components. The first component is PT and OT. The second component is speech. The third is skilled nursing. And the fourth is non-traditional, non-therapeutic ancillary services, like your CNAs. Are they helping them eat? Are they helping them dress? Are they helping them toilet? Those type of things. And what we found in this study is that they looked at 623 nursing homes across 35 states, and they found that 587 of them were for profit. Exactly 36 were for nonprofit. And then there was 1.6% that didn't, they put Z's in their UB04. So that what they did is they haven't entered the correct codes yet, so those were dismissed from the study because they don't know what their rates will be. Now, some astonishing facts about it is that these homes, they had an average bed of 148 beds. They had an average Medicare A stay of 16.7 people, and I gotta refer to my notes because I didn't memorize everything. I apologize. With the RUG-4 rate, if you look at the 2019 average, the RUG-4 rate average was $562.89, and the PDPM realized rate was $614.96. Which means that they're actually getting reimbursed at a higher rate with PDPM. which begs the question, why did they get rid of so many therapists? 3% across the board in the U.S. I believe one of the largest firms are congratulating themselves that they're going to show a quarterly bump of $30 million to their stockholders because they let all those people go. Now, as we all know, when you right size or downsize or fire licensed professionals or not licensed professionals, just if you fire anybody in general, you downsize, it makes people paranoid, and that's for a different talk, not this one. So anyway, what's going on with PDPM? Well, there's some astonishing differences. The things that they found is that the standard deviation was 2 deviations. If you people that love statistics, that's the formula. SX equals that. 2 standard deviations is actually covers 95%. That means that it's 2 deviations from the mean. Excuse me. So it covers most of them. And what they found is that physical therapy and OT therapy, the variance in their billing practices was only around 1.4%. Speech variance was actually in the rates of 65%. They found that a lot of the coding included neurological deficits. However, the difference was that it didn't include any swallowing or aphasia differences. So that needs to be researched further. The biggest difference is that nursing variance was about 35.1%. And the primary thing that they're missing in nursing is that they're not capturing the depression codes. And they reference in the article that if you look at your individuals that score 2 and you're not coding appropriately in the UBO4, that you're losing dollars on a daily basis. Now I had those differences highlighted in here. How about the weather we're having? Anyway, the differences for nursing averages anywhere between $30 and $40 a day. Now, if you have 16.7 individuals, I don't know how you have a 0.7 individual. Well, I guess maybe they're missing an arm or something, but at $30 a day, that's $504 you're leaving on the table just from not capturing your code. And if it's $40 a day, it's $668 that you're leaving on the table. The other discrepancy is in the non-therapeutic ancillary, which pays about $10 a day, which would give you another $167 a day. And that's just due to coding issues. So if you add all those up quickly, there's 12, 19, 13, 11, 12. $1,239 a day just by missing your codes. That's a simple fix, folks. Make sure that you're coding appropriately. Make sure that you're capturing your non-traditional ancillary services. You got your nurses capturing your depression. You got to look at your speech. Make sure that they're coding appropriately. If they're coding 65% of them neurological, and there was actually a 40% increase in September versus October, even though it's the same patient, in these differences in coding. So that's about $25 a day that they're capturing more for speech. which I'm sure they're gonna investigate further. It's a learning curve. It's a bell curve. It's making more money than the old rug system did, and you can also make more money just by coding correctly. So that's all I have for now. They expect it, as the learning curve increases, they expect it to, the average to go up to around $644 per day per individual. You know, $1,200, how many more CNAs would that give you in your skilled nursing facility? How many more RNs would it give you per day? I mean, pick one. Which one do you want? If you're gonna all put that in just profit, you know, your scores might be going down and you might not have your admits coming in as quickly as you would like. Your scores mean your 5-star score versus a 4 versus a 3. There's a big discrepancy in people's choices of where they want to go. The lower you score, the less likely they're going to want to go to your facility. They don't want to investigate why you have a 2. They just say, oh, they're a 2, they're a 5. Let me go to the 5. You know, when we go to restaurants, when we pick hotels, do you want to stay at a 1-star hotel in a country you're not familiar with, or are you going to look for a 4 or 5-star hotel just to be safe? You know, the answer is obvious. Be a 5. Anyway, that's Jeffrey Flack talking about the old rug system versus PDPM. If you want to look at the study yourself, look at Skilled Nursing News and look at the results by the Zimmerman Group and their core factor. Thanks, and I'm grateful for you watching. Have a great Black Friday. Flack out.